Hello, we've got another great episode of Talking Trisomy where we talk all things trisomy. Today is a unique experience for me. I have a chance to be joined by my co-host, John. We're going to still give you the co-host title, Dr. John Kari. If you've watched any of our other podcasts, you know how amazing he is, and all the many accolades that he's received over his career are well-deserved in the field of trisomy. And then I'm also joined by Kris Holladay. These two founded Soft. We have Kris Holladay, the parent founder, and John, the medical professional founder. So what a privilege for me having the chance we're going to tell some stories, we're going to talk, but today we're going to get a little bit into the details of this topic, which is trisomy and the difference between their eponyms. What I mean by that, John, you just educated me on this. But eponyms, so trisomy 18 is often referred to as Edwards syndrome. Now that's where it gets a little tricky, and that's where we're going to talk today, because Edwards syndrome is not always, I'm going to stutter. I'm going to let John explain the differences and the similarities between these two. Then we're going to talk a little bit about the same thing when it comes to trisomy 13 is frequently referred to as Patau syndrome. And yes, sometimes it is and sometimes it isn't. And same thing happens with a lot of our families here in Soft. I have trisomy 9 children, and there's mosaicism, and there's partial. And so we're just going to talk all things trisomy and their eponyms and their naming and what it means, and really get into the genetics of this, which is John's forte. But before we do that, Kris, let's tell the story how this conversation came about, because just in the last 2 years, let me get my prop here. We've got the Trisomy 18 book that we were putting together. This one we've talked about a lot for new and expectant parent resource guide. And so John and Kris and about 10 other people were working on it. And Kris, tell me what happened. You guys were working on this and some technical discussions came about, which has led us to this point where we're making a podcast about it.
Thank you. Glad to be here, and I'm honored to be on the screen with you, Nick and John Kari. Thank you very much. It's interesting, having been in this arena. Kari was born with trisomy 18 in 1977. So when I had the privilege of doing some editing and finishing touches on the Trisomy 18 prenatal book, a brand new book coming out for Soft 2 years ago, I asked Barb Van Herway to also take a look at it for me. And as we were discussing it, we noticed that at times the word trisomy 18 was used in the text, and other times Edwards syndrome was also in the text. And we became somewhat confused as to why the inconsistency throughout the book. And so we called John. And on a conference call, John brought to our awareness the difference between trisomy 18 and Edwards syndrome. And then we made some decisions together, how we would proceed with the trisomy 18 book, how we would refer to this syndrome, where we would refer to it as Edwards, when we would use trisomy 18, and how that came about. But the bottom line, the most interesting part was, after 40 plus years in working with lots of different families, offering support, understanding information, it was the first time I had ever heard there was a difference between trisomy 18 and Edwards syndrome. And also that brought us to ask the next question, well, is Patau syndrome different than trisomy 13? And John took his time to describe to these two now older mothers, and even though we'd been in this arena, we didn't understand until John helped us understand. So that's what came about with this conversation. And I wondered to myself, if I didn't know the difference, who else didn't understand the difference and this similarity? And John then brought himself to this place where we're going to describe it. So thank you for asking the history.
Yeah, it's going to be fascinating. Now, buckle up. John, I could sit and listen to you But we may, I mean, you get into the details. John, I would advise you, let's start high level and then we'll dive in deeper as we get into the podcast. So, Kris, John, tell us how that evolved. Tell us about that conversation. Let's start getting into the nitty gritty of the differences, the similarities. What makes Edwards syndrome? How do we spell Edwards syndrome? I'm just kidding. We were just talking about that offline. There's so many cool things that I think everybody will like to hear. So let's get into that.
So since Edwards syndrome was a term kind of came first, although they were intertwined in the original paper, we didn't know what the extra chromosome was. So I could say, okay, Edwards syndrome came first. Let's start with Edwards syndrome. So Edwards syndrome is the pattern and collection and set of physical findings, sometimes problems, sometimes birth defects, that go together to make up that particular condition. So a syndrome is a pattern. It's a constellation. It's a set. And so when John Edwards described the young lady near Oxford University, that was the first paper in 1960, he described a number of physical features as well as some of the other medical issues she had. And that became Edwards syndrome. At the same time, he knew about Down syndrome. So he took a blood sample from the hospital near Oxford, took it back to his cell biologist, and they were just working out how to do chromosomes at that time. This was now a year before 1960. This was not 1959. And they had just discovered that Down syndrome was due to having an extra 21. So John Edwards said, well, maybe this particular condition is due to another extra chromosome. And he was right. But at the time, the syndromes were hard to distinguish. I won't go into the detail when they looked at them under the microscope. So they called it 17-18. And later on, it was in the next paper that was published by Dr. David Smith in America that they said, yeah, this is 18. So the Edwards syndrome was due to having an extra copy of the chromosome known to be number 18, just like a year before, the syndrome described by John Langdon Down in the 1800s was now in 1959 due to an extra chromosome of the number that was called 21. So that's sort of how things come about. Over the years, people will say Edwards syndrome or trisomy 18. Edwards syndrome, also known as trisomy 18. You'll see that in the beginning sentence of almost any sort of paper. Now, if they had said Edwards syndrome, also known as full trisomy 18, it would be accurate. Or if they said Edwards syndrome, also known as full trisomy 18 syndrome, it would be accurate. Although we don't tend to use that wordiness there. But the confusion is that Edwards syndrome is this pattern of findings described by John Edwards, now recognized by both newborn doctors or, even if there isn't a prenatal diagnosis, newborn nurses, by the pattern of physical findings, which we can discuss again in a few moments. Trisomy 18 is the genetic, in this case, chromosomal. Chromosomes are part of the genetic condition, the extra chromosome seen. So trisomy 18 is referring to what geneticists would call the genotype, that is the genetic constitution, while Edwards syndrome, using that term, is part of what the geneticists would call the pattern of physical traits, that is the phenotype. But now, in the shortcut way we talk about things, we make them synonymous, which is okay, as long as we still really know, which is which. So in that sense, people will frequently say, well, trisomy 18 occurs in 1 in 6,000 live-born infants. Well, they should really be saying trisomy 18 syndrome is really seen, but they'll shorthand it and say just trisomy 18. But it does get confusing, and it it informs, or let's say drives, the issue about partial trisomy 18 and trisomy 18 mosaicism. And so nowadays it's very, very common for parents to already ask a question in the newborn period. Well, could she have mosaicism of trisomy 13? Or could she have mosaicism of trisomy 18? Knowing kind of already, because they've read about it, what the implications might be. But it's part of that discussion, because the average child with partial trisomy 18, and it depends on what part of the 18 is extra, doesn't have the Edwards syndrome. They might have components of the Edwards syndrome. They might have parts of it, partial, but they don't have the condition that John Edwards described. And same paragraph, the same would go with trisomy 18 mosaicism. Some children with trisomy 18 mosaicism are born. The newborn doctors said, remember, trisomy 18 is the genotype. The child's born. They'll look at the baby. Oh, this looks like the baby has trisomy 18, meaning this baby looks like she's going to have an extra 18 when we do the chromosome study. And they'll do it. And they'll say, oh, well, look at this. 15 cells had the extra 18, but 5 were so-called normal. They had 46 chromosomes. She has trisomy 18 mosaicism. Yet, physically, they were thinking that she had Edwards syndrome. So if you're still with me, hope you're still with me, it's sort of following a logic. Then we know other children with trisomy 18 mosaicism, that's their genotype, that's their chromosome finding, who you wouldn't even have thought they had Edwards syndrome. At birth, later on, or maybe when they're diagnosed at 8 years of age with developmental delay and someone is evaluating them and does a chromosome study, a karyotype, and finds that they have 20% of their cells, 4 out of the 20 on a chromosome sample has an extra 18, yet the idea that they had trisomy 18 never came up. And there are children we know with trisomy 18 diagnosed sometime in the early months of life who, when they're first diagnosed, they have full, complete 20 cells, all with trisomy 18. Yet later on, another sample, maybe blood, maybe a different tissue, they end up having a normal cell line with the trisomy 18 cell line. And now we know they have that their genotype, which affects the phenotype, because the genotype dictates the physical traits, right? The genotype is, in fact, trisomy 18 mosaicism. Everything I just said could easily be applied to trisomy 13. That is, partial trisomy 13, where a baby has a third of the bottom part of the 13 extra, but that's all that's extra in their particular genotype, their particular karyotype. They would not have been diagnosed with Patau syndrome. They would, however, they or he or she, have an extra finger and an extra toe, because the genes that are important for that part of Patau syndrome are on that part of the 13. Yet the child doesn't have full Patau syndrome. I hope everyone's with me on this. I mean, you have to be thinking the genetic finding, the extra chromosome, whether it's mosaic, partial, or full, versus the pattern of physical traits and characteristics that our child has. So that's really the difference. So most of the time, if we say Edwards syndrome, i.e. trisomy 18, most of the time we're right, because of those that are diagnosed with trisomy 18 of any type, 95% of them have full, complete trisomy 18. So most of the time, it's okay that we might be making them synonymous. But it's not okay all the time, because it would be confusing when a child really doesn't have Edwards syndrome, really doesn't have the same mortality figures, really doesn't have the same degrees of developmental disability, yet we're calling them trisomy 18. If I hope you're seeing my logic. So maybe if I've said too much and because it's confusing, Nick and Kris, you can ask questions to clarify some of these things I've said.
Well, that's amazing. I think there's two things. Kris, let me warn you. If you want to help me define mosaicism and partial, but John, I thought you did an excellent job. We might have to find a graphic artist to help us like have John talking with like the map, like some sort of graphic thing. That was pretty cool. What I want to like really highlight real quick is the fact that if we just assume and make that assumption that every child with trisomy 18 has Edwards syndrome or everyone has full trisomy, I think, John, where my logic mind was going is that every child could be unique. And so as we've had many of these podcasts and we've talked about it a lot, we want to support families here at Soft. We want to change the narrative. And that narrative we want to change is that every child should be treated as that child, not as a condition. So I think your explanation leads to ultimately what we hope as an organization, and we hope to change that narrative, that every child deserves a unique experience where the medical team and the parents can make their decisions that are best for that child. Because if we make assumptions that everyone's full, then we are going to be, mistaken, and there may be improper diagnoses. So thank you, John, for that. Kris, as I'm probably the dumbest person on this call, the least educated in this world when it comes to genetics, because Dr. Kari dwarfs me. And Kris, you've been thinking about this for many, many years, and I've heard many stories around the dinner table. Could you do your part of tell us what you thought of John's explanation?
I love hearing John talk. He always explains things at a level that I can understand, and I appreciate him being careful, using words that, again, when he says phenotype, genotype, he helps us understand the difference even between those two words, and I truly appreciate listening to him. I think what was interesting is that, as I think historically, Kari was born in 1977. Dr. Kari's talking about 1960. And even this is only, 15 to 17 years later, which in relative time is not very much time in the genetics arena. And information was still somewhat limited compared to today. I went back and I looked at my journals that I kept at that time, trying to understand what we were going through and wanting to record Kari's life and history because we thought it would be so brief. By the way, she did live to be almost 11 years old with what we were told was full trisomy 18. Nowhere in my journals did I ever read the words Edwards syndrome. And I'm not sure when I even became aware that those two were somewhat interchangeable. And so I'm not sure when that changed, because I did not know till today's podcast that Edwards syndrome was actually the first description of that condition, and trisomy 18 came later with the technology and the understanding of doing the karyotypes. I find that kind of an interesting thing. So within 15, 17 years, we had only heard the word trisomy 18. I'm not sure, again, if I'm answering the question you had asked, but I think the uniqueness of this syndrome is just underscored with what you just said, and that is every child is so unique and amongst their own, and how they developed before birth. What some children were majority with heart defects, but not all. And does that take them out of that full trisomy 18? Maybe, maybe not. We don't know. But every child should be looked at as an individual. And that was always our feeling when we would take Kari. And that was we wanted Kari to be seen as a child first and a syndrome second. And that medical decisions would be based on what she was telling us and what her body needed. And I feel like even back in the 1970s, 1980s, we were given that opportunity, and doctors were willing to look at her as an individual, even though at times it was a difficult journey to say child first, syndrome second. But as she proved herself, and she lived past a year, now she's into 2 years old, doctors were willing to say, yes, we're going to take a look at her as an individual. And that, I think, is what every parent wants for their child.
So I think, Nick, your point about changing the narrative, and Kris's point and your point about treating every child as the child and treating the problems as they come up, rather than the genetic diagnosis, the genetic label, is really the message. Because it's happened over the years that parents will have said to me at soft meetings and otherwise, they have realized that the child has full trisomy 18, but that with some repeated study, they find out they have mosaicism. And if they do, they very well could be treated differently. That's kind of important thing to note when we get to the place where it doesn't matter. I mean, in some ways, it should not matter. I mean, it matters in the sense that parents know that will learn, and is usually the case, that if one does have mosaicism and does have a normal cell line, that does inform differences in prognosis for both development and survival. And it also, this is the unfortunate part, may even play a role in whether someone will operate on a baby. So that the hope, maybe you should have mosaicism. I can think of two immediate examples of where that became an issue, where a child was operated on with the diagnosis of mosaicism of trisomy 18 and weren't going to be operated on before. But hopefully the narrative changes, and that what we're talking about now is a discussion of science and labeling and intellect and the rest, and not anything more than that. I mean, it's interesting and all the rest, but that it doesn't dictate the other part. So I like Nick and like Kris that you brought in that part. I do want to say something else about, I said when the three of us were talking beforehand, in that a child who turns out to have a genotype, chromosome finding, of mosaicism, 2 cell lines, normal and trisomy 18, may present at birth as having full trisomy 18. And later on, we learned by another sample that over the years, I have met many children with mosaicism who have gone from in the newborn ICU at Primary Children's. We thought they had a physical exam, full Edwards syndrome. We predicted full trisomy 18, and they had a normal cell line with mostly 18. But yet physically, we would think they would have the same pattern John Edwards described. From that to someone diagnosed at 6 or 7 months because they had some findings suggestive of some syndrome, developmental delay, chromosome study, they have normal cell line, and trisomy 18, they have mosaicism. To someone who you wouldn't even have raised that they had something that we tend to think of as important and potentially serious as trisomy 18 at the age of 4 or 5, and they're diagnosed to have trisomy 18 mosaic. And you can't always correlate the percentage of cells with how they present it. So that's the continuum. And I think maybe some of the audience here will know examples of someone who start at one end of that continuum going all the way to, at least I gave 3 examples. So one question is, and this has been raised for Down syndrome and trisomy 13 as well. I want to go back to why I said Down syndrome and not trisomy 31. Anyway, Down syndrome is, what is Edwards syndrome? What is the phenotype? And so I actually proposed in 2012 at a scientific meeting. I followed what had happened also in trisomy 21 Down syndrome and actually proposed a list of about a dozen, it was about probably 8, not a dozen, features that had to be present in some degree for someone to say, phenotypically, this person has Edwards syndrome with confidence. So that was never published. I don't know if it necessarily needs to be if we follow that sort of principles we're talking about. But either way, that came up. I said I wanted to go back to the Down syndrome. Almost everyone says, the press, scientific articles, they'll always tend to use Down syndrome first. Kris didn't know about Edwards syndrome till later on. Many people have a hard time knowing whether they should say Patau or Patau. I understand from my German friend, Dr. John Opitz, that it's Patau. I think of Patau. Anyway, don't have to worry about that with Edwards, except remember to leave his S on the end of Dr.
Edwards.
So Down syndrome was described in the 1860s. It was almost 100 years before we knew the extra chromosome. The condition was embedded in culture and society in truly a much different way. And of course, we've come a long way in acceptance overall, Down syndrome, disabilities, and so on. So I think those years of Down syndrome being embedded in the medical and even the general society culture leads to the fact that we always tend to say Down syndrome without saying Down syndrome / trisomy 21 or Down syndrome or trisomy 21, or to use trisomy 21 first. I think that's the reason. I don't know for sure. There's a lot of serendipity and a lot of randomness and unpredictability as to how we as pediatricians, especially, but also internists, have named medical conditions over the last few centuries, especially the last century, the 20th century. And it's not as organized, and because it would be hard to capture the name of a condition by naming it after a characteristic or two. That's why eponyms, that is the author of the first paper or the authors of the first paper, Prader-Willi syndrome, that's why eponyms kind of were the way to go for such a long time, especially in syndromes of birth defects and developmental delay. And we could go on and on with the list that probably many people in this audience know, not even they know the other ones because of families with them in early intervention programs and so on. Well, there are other names, and I won't go through them. There are other names besides naming after the doctor that described the first cases or case, whatever. Sometimes acronyms, using the letters that spell something out, like charge syndrome as an example. Or sometimes they'll even tend to use and almost use nothing else, the chromosome finding, like, of course, trisomy 9 mosaicism, without there being an accepted eponym. So I just wanted to mention that, because now it's with all these genes being discovered on a much more rapid basis, and we have a new syndrome described in only 21 patients in one article. What do we name that condition? The people that are doing the first description aren't going to be so, although I've seen this once, be so haughty as to say, let's call it by my name. We'll call it the whatchamacallit syndrome. And then after the next paper, they refer to it as the Smith syndrome or whatever it would be. But now the current trend, when a new gene is discovered and a phenotype is associated, what they'll do is they'll take the gene, and I'll just pick one as an example, SON dash related syndrome, or SON dash developmental delay dash related syndrome. So they're doing the gene and the phenotype and they're putting them both together. The genotype and the
Interesting.
phenotype are in the name of the condition. So we can do that too. Trisomy 18 syndrome. We don't even have to say, we could say trisomy 18-Edwards syndrome. So we're capturing the latest trend, the genotype first, followed by the phenotype, followed by what we have, what we're working with, that is the person syndrome.
Very interesting. John, thank you again. I keep learning from you. Old dogs can learn new tricks. So thank you for teaching me that. On the side of the naming and the names, I do want to just throw this in. In 1990, in St. Louis at the SOFT conference, we were privileged as the SOFT organization to have Dr. John Edwards and his lovely wife come to St. Louis. And we have such delightful pictures of him meeting so many of our kids here in the U.S. And some of the classic pictures are with John, of course, the two John doctors, and also with Kyle Harper. And I hope it was okay that I mentioned his name. They're just beautiful pictures with Dr. Edwards with the children. And we took him in a picture with all of the children lined up like we do traditionally at the SOFT conference. So I'm just throwing that one in, that sometimes you're actually lucky enough to be able to meet the doctor in whom that condition is named after.
When you were talking, I was looking around. I thought I had it on my desk, but it's over in another place. I do have a picture that Steve Cantrell gave me, I mentioned Steve's name, of Dr. Edwards with a bouquet of balloons at the balloon release.
Yes, he was allowed to release, the big bouquet that always symbolized all the unknown children born with trisomy 18, also 13 and related disorders. And he did release that. John, you're absolutely right. It was a remarkable experience to meet him. But nonetheless, trisomy 18 was the term we knew, and that's what we associated when we needed to have Kari treated. And it certainly didn't change how we felt about her being trisomy 18 or Edwards syndrome. She was still our child. She still had needs, and we needed to have those addressed. And she herself proved who she was, what she wanted, and what she needed. And we're grateful that regardless of what she was called, she was our child first. And we were grateful to have her be a part of our family. Nick, I treasure the pictures we have of you with your sister. And that is what really it boils down to, is the family, the parents, the siblings, and the condition is only secondary to who that person is. But Dr. Edwards, it was a treat to meet him. I had him sign the back of one of the pictures I had of Kari at that time. So that was a treat.
Nick, do I have time to tell a little bit of a story that's related to what Kris is talking about and Professor John Edwards?
We have unlimited footage. We'll just delete the boring stuff. Just kidding.
So I had
Go
met
ahead, John.
I had met John Edwards when I went to a conference in Oxford about one of the genetic conditions I was working with. And it was just such a delight to meet him. And he knew that I was connected with SOFT. And then a few years later, that's when came up with the idea. And it was actually John Harper and Steve who came up with the idea of inviting him, which we did. But he was ultimately the British professor. And it was not easy always to understand his accent. His wife was very easy to understand, but and he would always talk in sort of circuitous ways in some way. But I don't know if you remember his keynote address. In his keynote address, after he thanked us for inviting him, and he might have mentioned his wife, I don't remember, but he started talking, and none of us knew what he was talking about or why he was talking about what he was talking about. And he started talking about Mark Twain and captains on the Mississippi steamboat and the literary importance of Mark Twain being in the state of Missouri. And here we were now in St. Louis. And I don't remember how long it took him to get, well, why is he talking about this in relation to that? But he was reading something from Mark Twain, and then eventually he got to the point. Here we are, all congregating in a city on the Missouri River, not far from where where Mark Twain grew up. Anyway, it just was something, something I'll always remember and treasure, actually.
That's awesome.
That was especially unique coming from him being a doctor from England to then spend quite a bit of time talking about an American author and location. But yes, John, I do remember that. That was a treat. That was a treat. I don't know, Nick, again, thank you for your unlimited time on this. I did want to bring up one little tiny subject that might be tender for people. And I don't want to in any way step on anyone's hearts or feeling. But the subject has been broached, and that is that Edwards syndrome is a more gentle term than trisomy 18. And I don't want to in any way imply that that is less valid, but I've thought about that in quite a long time. Well, at least over the last 2 years since John explained to us on the phone what that meant, Edwards versus trisomy 18. I think for me, trisomy 18, because it was the first term we used, and it was a term I used when I was seeking help to Kari's condition, things that were needed, how we discussed her medical needs. Trisomy 18 never felt unkind. It was just simply a term used to describe possible needs and what to look for. Is there going to be hearing loss? Is there vision issues, feeding issues? And it was just the gate that we opened to walk into the medical arena. So my thought was, I'm not sure, as delightful as Dr. Edwards and his lovely wife were, I've never quite equated that term Edwards syndrome as being more gentle. It just is another term. To me, it's always the messaging and how that is described, how this condition is described, what it implies for your child or another child or children in general. It really hasn't, to me, ever felt like a more gentle term. It's always been a term to describe a message, and how that's interpreted by the parents, by the medical professionals as individuals is up to each other's definition of what that is. But trisomy 18 is no more harsh nor gentle than Edwards syndrome. But I do love that we're talking about what the differences are, because trisomy 18 is, my opinion, although a small percentage of mosaicism or partial, is still more inclusive of anyone who is born with whether a few or a lot of extra cells on the 18th, or the same with Patau, whether they're born with a few or a lot of extra 13th chromosome. It's the messaging of what that means to the child, to the family, more so than the description or the name itself. I think trisomy 18 to me has been more inclusive, because it does include all of those with the other variations, although a small percentage. It's the message, not necessarily the name of it. And trisomy 18 neither means heartache or celebration. It just is. For me, I celebrate the fact that we had a daughter who was born with trisomy 18 and enriched our lives in a way that we never, ever could have thought those first few days after her birth, which leads us now to this podcast with you, Nick, which is absolutely so gratifying. So I hope that I said that with enough kindness that those who felt differently than me are not offended in any way. Thank you.
Kris, I'm reminded when you mentioned that, and thank you for that clarification, I would underscore everything you said, as of course the message is the important point, and treating everyone as a child and based on their medical conditions is kind of the takeaway message.
John, what Dr. Patau, having the opportunity to meet Dr. Edwards, what about Dr. Patau? Who was he? Where did he come from? I don't know as much about him.
Good question. So Dr. Patau, Dr. Opitz told me, Patau, Dr. John Opitz, Smith-Lemli-Opitz syndrome, many other syndromes, one of the fathers of medical genetics and one of my mentors. Being from Germany, knew a lot about Patau, and he trained with him. John was a pediatric resident in Iowa in 59, when he applied to be a trainee at University of Wisconsin in Madison, where Patau was, Klaus Patau. Klaus Patau left Germany before the Nazis took over, but he saw what was coming. So he was a refugee from Nazi Germany, but he was a cell biologist in Germany. And I don't remember the story, although Dr. Opitz has probably told me before, that how he got into University of Wisconsin and became a leading, again, cell biologist, and then got into cytogenetics. He wasn't a clinician, he wasn't a physician. But when David Smith, the so-called father of dysmorphology, the study of syndromes and such, left his pediatric practice and came and worked with Patau, they actually saw the first child together with both trisomy 18 and trisomy 13. So they saw the child with trisomy 13 who had a bilateral cleft lip, extra fingers, and small eyes, and they worked it out that they were going to submit the paper of that child, with Dr. Patau being the first author and Dr. Smith being the second author, and the other authors were people in the lab that I don't remember their names now. But Smith was, so it could have been called the Patau-Smith syndrome, but the way it's the serendipitous nature of naming syndromes, that's not the way it evolved. It was at least in the 60s, just like Edwards' Patau syndrome. In the meantime, Dr. Smith had seen two children, which we now know had Edwards syndrome dash trisomy 18, full trisomy 18. He got that manuscript together. Patau submitted to Lancet, the journal, the first patient with trisomy 13 Patau syndrome. Meanwhile, John Edwards submitted his paper. The editors of Lancet said, these papers are really important. The third syndrome with trisomy after Down syndrome, after Klinefelter XXY, we're going to feature these syndromes together. Meanwhile, Dr. Smith is still preparing his paper on the first two patients he had seen with trisomy 18, where he's the first author. Patau is the second author. He submits it to Journal of Pediatrics. And then when he sees his paper in Lancet with the trisomy 13, he sees that somebody has scooped him on John Edwards on trisomy 17-18. Meanwhile, his paper is still being reviewed in Journal of Pediatrics. So again, someone might have said, well, look, Smith's paper only followed Edwards' paper by 4 months. We should be calling this the Edwards-Smith syndrome. That never happened, though. But anyway, that again related to that kind of unpredictability, almost randomness of, people have discovered a syndromes named for the doctor, and then they discover, wait a minute, that was described 50 years before by so-and-so. Shouldn't we be calling it that? Anyway.
That's the case made for trisomy 18, trisomy 13.
It's the case in genetics now for naming a syndrome by the actual genotype cause first, and then with a hyphen, leading to maybe a important physical finding, maybe even referring to the whole combination as the syndrome.
If we have time, I have one more question for John. And that is, all of this became in polite, like we had mentioned before, with the writing of that prenatal book, Trisomy 18, and thus then Trisomy 13. We've even written the prenatal book for Trisomy 9. And right now, I'm happy to say that the all have been translated into Spanish. We have yet to, but close to printing the Trisomy 9 prenatal book into Spanish as we speak. However, my question is this, John. We'll go back to that very first book, Trisomy 18, the prenatal book for families. I remember I'm kind of the picture person, so I was asked to help select pictures, get them converted, and I love pictures. They mean so much to me, and I was honored to be a part of that group that did both the pictures and some edit and some reviewing of it after it was written. I remember when asking about the pictures, because I had some beautiful pictures of some children, and I was asked to only select those that were known to have full trisomy 18 for the prenatal book. Was there a reason that you had wanted to stay with full trisomy 18 pictures, which if you have the book and you would like to see those pictures, it is online at trisomy.org. The pictures are astoundingly beautiful of these gorgeous children, and you can see the love and care that they have in their lives. But it was full trisomy 18 pictures, and so I did make sure that that was the case. My question is, was there a reason why you wanted full trisomy 18 pictures?
I think my reasoning was at the time, and if I can think about it and go back to that, was that I was seeing this book for parents and the doctors and genetic counselors caring for them, much of the time coming upon this after a prenatal diagnosis is made, maybe by cell-free DNA, hopefully confirmed by amniocentesis and ultrasound, that where the issues of changing the narrative tend to focus and center, and hopefully will no longer be the case in the future, is on full complete trisomy 18. And so I thought it was important that we were providing, I would hope, I would aspire, I would strive for, that what we produced is about as balanced of a book, a set of information on 18 and 13 that you can find. And seeking that balance, accurate and balanced and current. But what is balanced? I mean, you mentioned, Kris, that, and I'm not even sure I can capture it in the beautiful way you did, about Kari enriching your life. I came to the point somewhere along the way in working in the fetal center, and you may have said, John, you came to that late. I came to talking to families where I thought it was really important to mention to families who were not have made up their minds, but were wrestling with, should we go for pure comfort care? In some cases, should we consider a termination? Should we go with intervention when the baby was born? I thought it was important to balance the overwhelming information about mortality and birth defects and medical complexity with sharing that, in my experience, families I knew, regardless of what happened, felt that their child enriched their lives. And I don't even know exactly how I said it at the time and what my script was, because you do have scripts sometimes in these clinical settings. But I still, that's a conversation I think I never heard anyone else really say it before in that context. Maybe a somewhat similar context in Down syndrome. Notice I said Down syndrome, both prenatally and early on. But I don't know that and here I am with all the years I had working, and it took me that long to get that, to really present balance. It was important to say that. And I would hope that among my colleagues that conversation would continue. Maybe there should be more to it than what I said. To present let's say, the most balanced presentation.
You have a good point on that. And historically, soft has been accused or given credit for, I don't know which one it is, being too hopeful. And I think we often would say, we're not giving hope, we're giving information, accurate information. Parents need to know and then interpret it however they wish to be hopeful or not hopeful. Not all families were encouraged to know that children were surviving even without intervention. It's how they wanted to interpret that information based on their own belief system, their own value system. But giving a balance, as you so well put that, is our goal. And then let families decide for themselves what they do with that balanced information, and the decisions they make based on their own child is, I think, the bottom line. And truly the hope that SOFT does bring is that we're providing the most accurate information for families to make the best decisions for them and for their child based on who that child is. But I know that accusation of being too hopeful was one that has been a difficult challenge, because all we want to give is information and let families make their choice. And we support them in those choices they make, because they know their child best. They know their medical team, and they know what they look for. I think the bottom line is that what you said is most important, regardless of that newborn period or that prenatal period. The vast majority of families, parents say, this child has enriched my life. That would include those that did not make it to birth or only lived shortly after birth. So hope isn't always tied to longevity. Hope is tied to respect, value, and understanding that parents want the best for their child, and longevity isn't always the result of that. What parents want is their child to be recognized and respected and appreciated for just who they are. So I love this podcast, because I think what we're trying to do is bring again clarity, information, and understanding as parents are prenatally diagnosed shortly after birth, or even in the case sometimes months after birth, that their child is valued and important, and we recognize their value in your family regardless of the medical conditions that they are challenged with. And we at SOFT are always happy to provide the best and the most accurate information, and balanced, as you said, Dr. Kari, balanced information for parents.
One thing you made me think of, Kris, and I never didn't know we would be getting there. This is what I would call one of the great conversations. And that is having a conversation, having a discussion like this with others, defining from, let's say, a parent's view and insight who has gone through all those journeys you just described, the varied journeys, as to what is balanced. I mean, it is important to say that there are these survival figures. And like, we know all I've heard is negative, hopeless kinds of things. There are these lists of birth defects, but there's also more. And Nick was with me together when we talked to Natalia at Lurie Children's, and I loved their brochure that it did include the list of, did have birth defects, it did have other medical issues, but it also had a whole page on what the children can do. Remember, Nick? And I said, I was really impressed that, so to me, they were balancing the rest. And I liked the way they did it in a sort of like little bubble diagram for all the different medical issues. And then the next page had what the children can do. So to me, a conversation about what is balanced. I'd like to say the book that Nick's been holding up is as close as we've gotten before in language, in written material, not just we, everyone. But there are other ways. And Lurie Children's booklet that Natalia, and I apologize for not remembering the nurse practitioner that she works with, had written. And this idea of my somehow coming to, it was very important for me to add with all these other facts and figures. Families find this experience and their child having enriched their lives. I mean, like we're getting there. You know what I mean? The tapestry has different pieces to it, but we should have that conversation.
Oh, wouldn't that be a fabulous one?
And then,
John, I love that. I love that Laurie's has the glass half full instead of glass half empty kind of approach, because that is a mindset. What can they do? And I think those kind of words and that kind of verbiage does lend itself to the balanced discussion. Wow.
To give credit, Natasha and Grace is the nurse practitioner. Both of them were on a podcast recently released. So whenever you're watching this one, find the Rolodex of videos. Both of them did an excellent job. And their group at Lurie's, the Trisomy Care Collaborative, is one of the leading institutions for what John's describing. Balanced and an effort to treat children with these conditions as children, and the different teams talk and the different teams meet, the different surgeons and pediatricians and all of that.
We got to convene. We got to convene all these people as people are asking these questions. But and thanks for reminding me of Grace's name.
She's a rock star. We love Lori's. Lori's some other doctors help us write Trisomy 9. So Chicago.
Thank Dr. you. Lee is there at Lurie Hospital with Natasha and with Grace.
Yep. And so what wonderful experiences, and John, I love that you brought that up, because there are, I'm a sibling. I always like to put on my sibling hat at some point in a podcast. And having had Kari, I was younger than Kari. And the Holladay family also has, I have a younger sister that has a different set of challenges and disabilities and what have you. And both of them enriched my life. Neither of them have said a word to me. Savannah, my younger sister, has signed to me. She knows some basic sign language, and that nonverbal communication. I think Josh Bradley, our chairman of SOFT, always talks about the power of nonverbal, and that's something that he has missed since losing Dawson. And so there's just all sorts of variables and passions and life experiences that come. And one I want to highlight real quick, Kris, you said it before we hit recording, was how many people we have met because of Kari. I think of the hundreds, if not thousands, of families that we have met. We're going to say thousands, because we have thousands of people on our newsletter list. And so the hundreds of people that come to conference every year, and they come at different times and seasons and different localities, if they can drive to conference, they'll be there. So literally getting together with thousands of people over the last 40 years has been a difference maker. One thing I just want to add, I know when the three of us get together, we get long in the tooth when we talk. And so if you're still with us, the one thing about, I think, a lot of our SOFT families isn't unique to the Holladay family, is we have this kind of, because trisomy 18, trisomy 13, trisomy 9, it's rare enough that in your neighborhood, you're probably one of a kind, right? At your congregation, your church congregation, at your elementary school, even in your high school district, which is usually fairly, a couple miles worth of humans, you might be the only one, and you might be the only one in your metroplex. And you get my point. So you feel fairly unique, but we have this like hidden family, and it's the SOFT family, or it's the, even amongst other organizations, And I won't name one because I'll forget someone, but all these many other support organizations that do very cool things. How many friendships and connections and conferences, not just the soft conference that we go to, that our families go to, that now you have this like hidden. And so I was talking to a friend of mine who's known me for, I don't know, I don't want to say how old I am, but for 90% of my life, I went to lunch with him. I hadn't seen him in a few years. And he's like, "What are you doing?" I said, "Well, I'm helping Soft." And he's like, "What?" And so I had to describe what we did. He's like, "Oh, yeah, I remember that as a kid. You'd go to these summer things and you'd disappear for a week." And it was interesting to me to think about how enriched my life personally and my extended family, because each of you listening, whether we've met or not, you're part of my Trisomy family. And what a unique thing. And so if I go into the enrichment of Kari, it is wild to think what she's done in 11 years has perpetrated into thousands upon thousands of interactions and life-changing events, life-changing opinions and friendships and stories, that is somewhat of a secret to my neighbor. So it's kind of fun. Anyway, there you go. There's our secret family, this soft family, the Trisomy community. We kind of just, it is. So anyway, I could go on and on about that, but that's my perspective. And I'm so excited to hopefully find more families as the years go by. So join in. Send us messages. This is Talking Trisomy, and we came up with that name because all we do is talk trisomy. And so today was really nitty-gritty details of how these names came to be, who found it, how that discovered. Pretty exciting. And so just over the last, if I can do my math right, 70 years or so, a lot has changed, and a lot has been changing in the last 6 months, 9 months, 3 years in particular. So we hope that, as John said, we'll want to stay on the cutting edge of the information and remain in the spot where we give balanced information so you families can choose what to do. As part of that information, I encourage people to watch other family stories. We have podcasts, and we'll keep growing. We're up to over a dozen podcasts that include doctor interviews, that includes family interviews, families that had children that lived only hours or days, and children and interviews with families that have children that are in their teens and beyond. And anyway, we'll see the Hayes family here at conference. And so anyway, just if you want to get a different perspective when you are ready, when you want to, please check out those stories, our podcasts, our blogs, any of those things written and these recordings. So thank you everyone for listening. Again, this is another episode of Talking Trisomy where we got into the scientific side of things. So I learned a lot. I hope you did too. Thank you, Dr. Kari. Thank you, Kris Holladay. And again, another wonderful episode of Talking Trisomy. We'll see you next time.
Thank you.